In this lecture, we will discuss the different kinds of thyroid malignancies. Thyroid malignancies are more common in females. It is 4 times more likely in females compared with males. There are 2 types of thyroid malignancies. They are primary and secondaries. Primary thyroid malignancies arise from follicular cells or parafollicular cells or sometimes from lymphoid tissues. If we consider the primary thyroid malignancies, the malignancies arise from follicular cells are divided into 2. They are differentiated thyroid cancers and poorly differentiated thyroid cancers. Differentiated thyroid cancers are 3 kinds: papillary thyroid cancers, follicular thyroid cancers, and Hurtle cell carcinomas. Poorly differentiated thyroid cancers are anaplastic thyroid cancers. The cancers arise from parafollicular C cells are medullary thyroid cancers. The primary thyroid lymphomas arise from lymphoid tissues. In a normal thyroid gland, there are no lymphoid tissues within the gland. So the primary thyroid lymphomas originate from the lymphoid aggregates developed in autoimmune thyroiditis. Secondary thyroid malignancies are due to metastatic spreads, most commonly from renal cell carcinoma, or there are some local infiltration from adjacent structures such as larynx and esophagus. Differentiated thyroid cancers are the commonest type. In this, about 80% are papillary thyroid cancers. What are the presentations of thyroid cancers? The most common presentation is recent rapid enlargement of the thyroid gland, but this should be differentiated from bleeding into a nodule. Enlarged cervical lymph nodes are important presentation of thyroid cancers, especially in papillary and medullary thyroid cancers. Hoarseness of voice is due to the infiltration to the recurrent laryngeal nerves. This is very suggestive of locally advanced disease. There can be a referred pain over the ear. This is suggestive of nerve involvement from infiltrating tumors. There are suspicious features of thyroid malignancies. The features give rise to high suspicion are family history of thyroid malignancy or MEN syndrome, rapid tumor growth, very firm thyroid nodules, fixity of the gland to the adjacent structures, vocal cord paralysis, cervical lymphadenopathy, or distant metastasis identified in the lungs or bones with thyroid lump. The moderate suspicions are when the thyroid gland appear in the extremes of age, that is less than 20 years or more than 60 years of age. Male sex, solitary nodule, and when a nodule size is more than 4 cm also indicate moderate suspicions. The other moderate suspicious features are history of head and neck irradiation and compressive symptoms. There are tumor markers used in the follow-up of thyroid cancers. They are mainly thyroglobulins and calcitonin. Thyroglobulins are tumor markers for papillary and follicular thyroid cancers. Calcitonin is used in medullary thyroid cancers. These tumor markers are used for follow-up of these thyroid malignancies, but they are not helpful to diagnose such cancers. There are no tumor markers for anaplastic thyroid cancers. First, we will discuss the differentiated thyroid carcinoma. Differentiated thyroid carcinomas arise from follicular cells. These cancers are TSH dependent. There are 3 types of differentiated thyroid cancers. They are papillary thyroid cancers, follicular thyroid cancers, and Hurtle cell cancers. Papillary thyroid cancers are the commonest thyroid malignancy. It is common in young patients. The known etiologies for the papillary thyroid cancers are exposure to ionizing radiation or familial. Ionizing radiation is the only clearly established environmental risk factor for papillary thyroid cancer. Papillary thyroid cancers can present with features of distant metastasis without detectable thyroid mass. It is called occult micrometastasis. Papillary thyroid cancers are malignancy of the epithelial follicular cells. It has a unique nuclear features where the nuclei typically show a clear or ground glass appearance. This empty cellular appearance is similar to the eyes of the cartoon character Little Orphan Annie. So this is called Orphan Annie eye nuclei. Other histological appearances of papillary thyroid cancer are multinucleated giant cells and psammoma bodies. There are three main histopathological variants of papillary thyroid carcinoma. They are microcarcinomas, follicular variants, and aggressive variant. Microcarcinomas are papillary cancers with less or equal to 1 cm size of a nodule or a tumor. It has an excellent prognosis even though there are 30% of cervical lymph node involvement. Aggressive variants are found in older patients. The typical spread of papillary thyroid cancers are to the cervical lymph nodes, but the hematogenous spread are uncommon. About 70% of papillary thyroid cancers are multicentric or multifocal. The second type of differentiated thyroid cancer is follicular thyroid cancer. It is a disease of an older population compared with papillary thyroid cancer. The peak incidence is 40 to 60 years. The incidence of follicular thyroid cancer is high in endemic goitrous areas, possibly due to TSH stimulation. Follicular thyroid cancers and multinodular goiter coexist in about 10% of cases. In contrast to papillary thyroid cancer, follicular thyroid cancer is not strongly associated with radiation exposure. The mortality rate is twice that of papillary thyroid cancer. Follicular thyroid cancer, also as papillary, arises from epithelial follicular cells. It differs from papillary thyroid cancer in that follicular thyroid cancer lacks diagnostic nuclear features. Follicular thyroid cancer cannot be diagnosed with FNAC because the follicular cancers differ from follicular adenoma in that the cancers have capsular and vascular invasion which cannot be identified with FNAC. So follicular cancers are only be diagnosed by histological confirmation. Lymph node metastasis is less common in follicular cancers, but the hematogenous spread is more common, and common spread are mainly to bone and lungs. Bone secondaries are very vascular, and this presents with pulsatile bonilum commonly in skull, long bones and ribs. Histopathologically, there are two types of follicular thyroid cancers. They are minimally invasive and widely invasive. The third type of differentiated thyroid cancer is Hurtle cell carcinoma. Earlier it was considered as a variant of follicular thyroid cancer, but currently it is considered as a separate entity. This consists of oxyphilic cells and commonly occurs in older females, usually 60 to 75 years. It tends to cause local recurrence and it has more aggressive biologic behavior. If we consider the management of differentiated thyroid cancer, there are two kinds. Mainstay of management is surgery. The second kind of management is adjuvant treatments. Surgical management should concentrate on thyroidectomy and cervical lymph node dissection. Adjuvant treatments are radioactive iodine therapy and TSH suppression therapy. In papillary thyroid cancer, the tumor size is more than 1 centimeter, then the total thyroidectomy is the preferred choice. But in microcarcinomas, where the tumor size is less than 1 centimeter, the hemithyroidectomy is undertaken, provided that the tumor is well differentiated, unifocal, and intrathyroidal. But if there are any history of head and neck irradiation or family history of papillary thyroid cancer or any evidence of cervical lymph node metastasis in microcarcinomas, the total thyroidectomy is recommended. As follicular carcinomas are not diagnosed with FNAC, a hemithyroidectomy was done for solitary nodule shows cellular atypia or follicular neoplasm in FNAC. When follicular carcinoma is confirmed with histology, the completion thyroidectomy should be done. The exceptions for completion thyroidectomy are unifocal tumor, low risk with minimally invasive tumor, intrathyroidal tumor, negative cervical lymph nodes, and tumor sizes less than 1 centimeter. Total thyroidectomy rather than hemithyroidectomy is preferred in cases where the lesion is more than 4 cm, marked atypia on FNAC, family history of thyroid cancer, history of radiation to head and neck, bilateral nodal disease, and patient's wish. Lymph node dissection to be decided for two areas of lymph nodes, that is, central lymph node and lateral lymph nodes. Central lymph node, that is level 6, dissection is considered when there are clinically detectable metastatic lymph nodes in the central region, or level 6. Lateral lymph nodes, that is level 2, 3 and 4 dissection to be considered with FNAC proven lymph node metastasis in cases of clinically or ultrasonically suspicious lymph nodes. Next treatment modality is the adjuvant treatment. The adjuvant treatment for differentiated thyroid cancers are radioactive iodine, ablation, and TSH suppression therapy. Radioactive iodine is indicated in distant metastasis, gross extrathyroidal extension when primary tumor is more than 4 cm in size, regional lymph node metastasis, and presence of high-risk features. As papillary thyroid cancers and follicular thyroid cancers are TSH dependent, a suppressive therapy of TSH with thyroxine is beneficial in some patients. The degrees of suppression is depend on the level of risk of recurrence. Long-term TSH suppression will lead to cardiac arrhythmias and osteoporosis. So the risk versus benefit should be considered when using the TSH suppression therapy. The prognostic risk classification for patients with differentiated thyroid carcinomas are considered according to AMES or ages classification. In that, the age, sex, extent of the thyroid, metastasis, size of the tumor, and grade are considered. According to that factors, the risk is classified as low risk and high risk. Previously, the lymph node status was not considered as prognostic indicator, but currently the lymph node metastasis impairs the prognosis. If a young patient presents with lymph node metastasis, it will increase the risk of local recurrence, but it won't affect the mortality. If lymph node metastasis occur in older patients, then it will increase the risk of local recurrence and mortality. The TNM classification for the differentiated thyroid carcinoma is necessary for the prognostic staging. The stages indicate the expected 10-year disease-specific survival. You can understand here that there is no change in prognosis in individuals less than 55 years of age with even any tumor stage and any nodal stages. Prognosis in less than 55 years of age depends only with distant metastasis. Next, we will discuss the medullary thyroid carcinoma. It is about 2 to 3% of thyroid malignancies. Medullary thyroid cancers are a type of neuroendocrine tumor. It arises from parafollicular C cells. Like other neuroendocrine tumors, the progression of the medullary thyroid cancers are very slow. It is characterized by the RET gene mutation, and the medullary thyroid cancers are classified as hereditary and sporadic. 75% of medullary thyroid cancers are sporadic. Hereditary types are associated with either the autosomal dominant multiple endocrine neoplasia or a familial non-Men's syndromes. Hereditary disease occurs in young age. Sporadic disease can occur at any age, but commonly around the fourth decade. Diarrhea is a feature in 30% of cases of medullary thyroid cancer, and this may be due to 5-hydroxytryptamine or prostaglandins produced by the tumor cells. C-cell hyperplasia is a precursor to medullary thyroid carcinoma. There is a characteristic amyloid stroma is seen in the histological analysis. Lymph node metastases are common with medullary thyroid cancers. About 2/3 of the disease will have ipsilateral and 1/3 will have contralateral lymph node metastasis. Hematogenous spread also common, and it can metastasize to bone, liver and lung frequently. When investigating the medullary thyroid cancer, the routine triple investigations are the first line investigations such as thyroid function tests, ultrasound scan and FNAC. Medullary thyroid cancers can be diagnosed with FNAC. Calcitonin and CEA, that is carcinoembryonic antigen, are biomarkers or tumor markers in that the calcitonin is used to assess the recurrence of medullary thyroid cancers and the screening of family members. Medullary thyroid cancers can be associated with Men's syndrome. So the associated pheochromocytoma and parathyroid adenoma are investigated. RET mutation testing also important in medullary thyroid cancers. All first-degree relatives of an individual with germline RET mutation should undergo genetic testing. How do we treat medullary thyroid carcinomas? If a medullary thyroid cancer is diagnosed preoperatively, a total thyroidectomy with central lymph node dissection is done. Any involvement of lateral lymph nodes evident clinically, radiologically or histologically should be managed with an ipsilateral lateral lymph node dissection. In the presence of metastatic disease, a palliative total thyroidectomy and central lymph node dissection should be done. Medical therapy with tyrosine kinase inhibitors used for advanced disease have beneficial effects. Prophylactic thyroidectomy for RET gene positive family members need to be considered. Next, the most aggressive thyroid malignancy is anaplastic thyroid carcinoma. It arises from follicular cells and typically affects elderly women. The patients present with a rapid neck swelling, visceral invasions and distant metastasis. At the time of diagnosis of anaplastic carcinoma, about 90% of patients have distant spread, most commonly to the lungs, indicate the aggressiveness. Diagnosis of anaplastic carcinomas is done with FNAC in 90% of cases. But in doubtful cases, the core biopsy is helpful to differentiate it from lymphomas because thyroid lymphoma can be incorrectly diagnosed as anaplastic cancer. It has very poor prognosis that almost all patients will die within 6 months of diagnosis. The treatment of anaplastic carcinoma is with chemo and radiotherapy, but solid evidence of effectiveness is lacking. Surgery is not an option for most of the patients, and sometimes the tracheostomy is performed for any impending airway obstruction. The other rare malignancy of the thyroid gland is primary thyroid lymphoma. There are no lymphoid tissues within the normal thyroid gland. The lymphoid tissues aggregates in autoimmune thyroiditis. So the primary thyroid lymphoma arises from a gland with thyroiditis. So the Hashimoto's thyroiditis is a strong risk factor for primary thyroid lymphoma. Non-Hodgkin B-cell lymphoma is the most common pathology. It is usually present in older patients with presentation of rapidly enlarging painless neck lump with local compressive features. The investigations are histology, immunohistochemistry, and flow cytometry. The main treatment option is chemoradiation. Surgery is reserved for palliative debulking in compressive neck disease. Prognosis is generally good if there is no cervical lymphadenopathy.